This is the Fetus and the Placenta Embryology tutorial presented by SchrDbb with reference Langman Medical Embryology by TW Sadler. So, we are going to start this tutorial by knowing what is the meaning of a fetus. So, a fetus is defined as any baby which is as from the second trimester. So everything that is as from the second trimester is referred to as a fetus in the uterus. Is it clear? So in the first trimester, so now the question you have to ask yourself is, what is the duration of the first, second, and the third trimester? The duration of the first trimester starts from the first day of fertilization till 13 weeks or till 12 weeks of gestation. The second trimester starts from 13 weeks of gestation till 28 weeks of gestation, and the third trimester starts from 28 weeks of gestation till birth. Is it clear? So usually third month can just be considered as the 12 weeks of gestation. Third month can be considered 12 weeks of gestation. That's why they say here third month till birth is considered as a fetus and placenta. Is it clear? So that's why this chapter is as such. Now the things that you have to know is, in order for you to monitor, in order for you to, when a mother has a baby, it's very good for us to know the approximate times of gestation. There should be methods for which the physicians will know the gestational age of the child, such that if the child is small for that particular gestational age, it can be a sign of pathology or not. Is it clear? So now the question is, how can you estimate the gestational age by using which method? There are different methods that can be used in estimating gestational age. The first one is that you can use the gestational sac diameter. So the gestational sac diameter can be used as from 0 to 5 weeks of gestation. Is it clear? Now the second thing that can be used is the crown to rump. The third thing that can be used is the biparietal diameter, and the fourth thing that can be used is the weight of the child. Other things that can also be used in estimating the weight can be the abdominal circumference, the femoral length, and the length of the child. So all that can be used in estimating the weight. So now the most precise in the measuring the gestational age is the crown to rump length, and this is a theory that shows the approximate the weeks of gestation, and then the crown to rump length that you are going to measure. And this is also a table showing the approximate weeks of gestation and the weight you are going to measure of the child. Now this diagram now shows the fetus at 9 weeks of gestation. Note that at 9 weeks of gestation you have a very large head size compared to the rest of the body. Now this is the yolk stalk here. So this is the yolk stalk here, this is the yolk sac here. So the yolk sac is very important because here this is where the child has, at the beginning you need to know that what this chorion has not been formed. So the child needs a store of energy from which it can take energy. Is it clear? So we need to know that at the beginning, when the child implants, there is no blood supply from the maternal circulation to the child. Is it clear? So at first, the child is going to receive nutrients from the yolk sac. That's why the yolk sac is very important. It is the initial store of energy of the child. So the child is going to receive the energy from the yolk sac, and now when the child the implantation has gone further, and then this syncytial trophoblast has been exposed to the maternal blood supply. Now the chorion now can be formed, which now is going to produce a placenta later, and as from the second trimester. And then when the placenta is going to be formed, now it's going to supply now the child through the umbilical artery. Now this now is the morphology of a child with respect to the different age. At the third month, the child has a very large cephalic region. The head is very large compared to the rest of the body, and then you see how the child is just like a frog. So the position of the child is a frog position. Now this one here, you see how the head gets smaller, and then the leg lengthens, and then here the head is still large, but the leg are more lengthened compared to when it's at fifth month. So now this is it. There are various imaging techniques to visualize the child at various gestational age. So at 11 weeks, you see the umbilical cord is still show is swelling at the base, and this swelling at the base shows that the abdominal wall has not been completely formed, and this swelling can show an omphalocele in utero. Is it clear? So you see also the finger, the toe, and toes are well developed at 11 weeks of gestation. So this imaging technique is mostly by magnetic resonance imaging and ultrasound technique. Why? Because magnetic resonance and ultrasound technique are not detrimental to the child. So what is detrimental to the child are radiations such as plain abdominal X-ray and also CT scans. So this one is not used. These ones are not used in imaging technique. Now the next year, you see this is another child at 12 weeks of gestation. So this child at 12 weeks of gestation, you see, you note here actually there is extremely thin skin and underlying blood vessels. The face has all the human characteristics. You see the ear, you see the eye, you see the nose, you see the mouth, all the human characteristics are on the face already by 12 weeks of gestation. So now at 18 weeks of gestation, what do you realize? 18 weeks of gestation is connected. You see the umbilical cord is connected to the placenta, and then the skin of the fetus is thin because of back of subcutaneous fat. Now here this is the placenta here with the different the cotyledons. You need to know that the placenta has two main sides. We have the maternal side of the placenta, which is connected to the blood vessels, and we have the fetal cells of the placenta, which is connected to the umbilical cord. The fetal side of the placenta is called the amnion, while the maternal side of the placenta is called the chorion. Is it clear? So now these are the developmental horizons of the different fetal events. So you need to know that the taste buds appear as from 7 weeks of gestation. So the child is already having certain taste sensation as from 7 weeks of gestation. So what the mother eats can affect the taste of the child. So there are certain things that the mother should not be exposed to, that because the child is going to be adapted to that taste and has a tendency of taking those tastes in later life. So example of these cases is when the mother takes alcohol, the child adapts to the taste of alcohol in utero, and when the child is going to be exposed to alcohol in later life, it's a very high chance for him to become alcoholic. Same with cigarette, but cigarette is not so a tasteful sensation. Is it clear? So different tastes that the child is exposed to in utero, he can have that affiliation to that taste later on in life. So because the taste bud appears at 7 weeks of gestation, swallowing occurs at 10 weeks of gestation, and this swallowing regulation is very important in the production of amniotic fluid. So both, you need to know that amniotic fluid is produced both by the maternal circulation through filtration and by the fetus through urination. Is it clear? The respiration movement starts as 14 to 16 weeks of gestation. Now the sucking reflex, the sucking movement starts as the 24 weeks of gestation. This is very important because if a child is born at 20 weeks of gestation, you should not start sucking in this child. Is it clear? So some sound can also be heard by the child as from 24 to 36 weeks of gestation. And also something very important that we should say is that the swallowing is not also very mature at when the child is at 34 weeks of gestation. When the child is below 34 weeks of gestation, the maturity of swallowing reflex increases when the child is more than 34 weeks of gestation. So the child is highly swallowing at that level. Sounds is heard also in utero. So when you make sound outside, the child can also have it. And then the eye sensitivity to light starts from 28 weeks of gestation. You see that eye sensitivity to light is the last to develop compared to the other senses. Is it clear? Now the clinical correlation to this are going to be, the first example is going to be low birth weight. So low birth weight is considered when the weight of the child at birth is less than 2,500 grams. Is it clear? So every child that at birth is less than 2,500 grams is said to be low birth weight. Now not all low birth weight are problems. Is it clear? So that's why we have certain types of definition. Example, if a child is born at 20 weeks of gestation and he has a weight of 2.3, though that child is low birth weight, but he may not be having any pathology. That's why there are other terms that have been used now, like intrauterine growth restriction and small for gestational age. Is it clear? Now, small definition. Let's define small for gestational age. Small for gestational age is defined as the birth weight which is less than the 10th percentile of the population of the same gestational age. I hope you are understanding what I just said. So when you have a birth weight of less than the 10th percentile of, that is 10%, when you have a birth weight of less than 10% of the population of those, say, of babies having the same gestational age like you, when you have a birth weight of less than 10% of babies having the same gestational age like you are said to be small for gestational age. Is it clear? Now, small for gestational age now can be pathological and non-pathological. I mean, example, there are some families that their children are all small, so it may not necessarily be a pathology that you are small for gestational age. Is it clear? So it may be just idiopathic or familial. Now, that is why that is the general term for small for gestational age. Now, in case where it is pathological small for gestational age, usually that word is better to say that it is intrauterine growth restriction. So intrauterine growth restriction is mostly pathological small for gestational age. So the definition is birth weight of less than 10 percentile of population of babies have of same gestational age, which is due to a pathology. Is it clear? Now, intrauterine growth restriction, the two main causes of intrauterine growth restriction are, one, so the two main causes now of low birth weight, the two main causes of low birth weight are intrauterine growth restriction, small for gestational age, and prematurity. Now, the causes now of intrauterine growth restriction is based on the division of intrauterine growth restriction. Is it clear? The intrauterine growth restriction is divided into two. We have symmetric intrauterine growth restriction and we have asymmetric intrauterine growth restriction. Symmetric intrauterine growth restriction occurs when the head and the learn and all the head circumference, the length, the chest circumference reduce proportionately. Why asymmetric intrauterine growth restriction occurs where the head circumference is normal but the length and the weight are small for gestational age. Is it clear? So when you have asymmetric intrauterine growth restriction, the pathology mostly occur after the second half of the pregnancy. So example of cases where you have asymmetric intrauterine growth restriction, you have preeclampsia, you have number one is preeclampsia, number two other certain forms of gestational diabetes, number three we have any hypoxia in pregnancy, any maternal disease like respiratory disorder, chronic obstructive pulmonary disease, and all that, any maternal infection that occur after 20 weeks of gestation. Now, for symmetric intrauterine growth restriction, mostly it occurs when the pathology was less than the first half of the pregnancy. Example, if you have infection with a torches infection during the first half of the pregnancy, if you have any disease in the mother during the first half of the pregnancy, may result to that symmetric intrauterine growth restriction. Now, the next thing that I wish to say now, you need to point out the fact that there are also long-term effects of this infant. For example, babies with intrauterine growth restriction have shown to have a greater chance of adults to have a metabolic diseases. Is it clear? So, and that hypothesis where babies with intrauterine growth restriction have higher chance of having metabolic diseases is called a Baker's hypothesis. Example of those metabolic diseases are shown under the metabolic syndrome, which consists of obesity, hypertension, hypercholesterolemia, consists of hyperglycemia, it consists of hyperuricemia, and that hyperglycemia shows that this child may have type 2 diabetes later in life. Okay. Now, the next thing to know is that what? You need to know that the child may be small because of intrauterine growth restriction, but there are also other causes why the child may be small. Is it clear? You need to know that what? In utero, the child responds to insulin-like growth factor 1. Is it clear? In utero, the child responds to insulin-like growth factor 1. Both which has an anabolic effect in the child. So when there is no secretion of that insulin-like growth factor 1, the child is going to have an intrauterine growth restriction. Now, but when the child now is out, when the child now is a fetus, is it clear? So when the child now is out the uterus, when the child is born, you need to know that it responds now to growth hormone and intrauterine growth factor 1 both together for its growth. Is it clear? So you need to know that what low level of growth hormone is not going to cause intrauterine growth restriction. Are you getting? So if the child has low level of growth hormone, it is not going to cause intrauterine growth restriction. Low level of growth hormone is going to now make the child not to have a good growth as time is going on. Is it clear? And that mutation now of growth hormone receptor, where the child has growth hormone receptor mutation, is called a Laron's dwarfism. Now, this is now the fetal membrane and the placenta formation. Now, you need to know that when the embryo implants, there are two main types of cells that are going to be covering the embryo, which are produced from the trophoblast. We have the syncytial trophoblast. The syncytial trophoblast are the what are going to be in contact with the uterus of the mother, while the cytotrophoblasts are what are going to produce now the embryo, both the intra and the extra coelomic cavity. So as you can see here, this is the embryo here. The embryo here you have the intra-embryonic cavity. Intra-embryonic cavity constitutes of the amniotic cavity, the yolk sac. Those are the intra-embryonic cavity, and we also have other intra-embryonic cavities like the pericardial cavity, the peritoneal cavity, and all that. Now these are the extra-embryonic cavity. So is it clear? So this one is the extra embryonic cavity, is outside. It does not make any part. It's never going to be found inside the child. Is it clear? This is the extra embryonic cavity now. So the extra embryonic cavity is also called the chorionic cavity because the cytotrophoblast, which is lining the uterus, which is going to be in contact with the uterus, is going to produce the chorion later in life. So we are going to have the chorion later in life, and that cavity that is produced between the chorion cavity and the amnion is going to be called the extra embryonic cavity or the chorionic cavity. Now this plate of the chorion here is going to be called the chorionic plate or the extra embryonic mesoderm. Now what the chorion is going to produce, they are going to produce intervillous space, and these are the different villi of the chorion. And now those villi of the chorion here, secondary and tertiary villi, are going to attach now to the spiral arch in order to produce the arterial supply to the fetus. And also those villi are going to attach also to the venous system, the spiral vein, in order to produce the venous system of the child. So here is the inner syncytial trophoblast, and here is the outer syncytial trophoblast. Is it clear? So those are the different things that you see. Now still here you can see here that what, so these are the cytotrophoblasts. The cytotrophoblasts are going to be both the syncytiotrophoblasts and the cytotrophoblasts are going to be in contact with the uterus, while the embryoblast is what is going to produce now the fetus. So this is the cytotrophoblast shell here. These are the different villi. The spiral arch is going to enter. This is the extra embryonic mesoderm, which is still produced by the cytotrophoblast and all that. Okay, so this is the intervillous space, and these are the different villi which are going to be connected to the arches, and these are the villous blood vessels. Is it clear? Now the barrier the barrier is by the syncytium. That is the cytotrophoblast. When you have the barrier, the barrier that connects both the embryo and then the mother. So that barrier is made up of the syncytium, which is the syncytotrophoblast 1. That's the first layer of the barrier. The second layer of the barrier is going to be by the cytotrophoblast. The third layer of the barrier is going to be by the connective tissue, and the fourth layer of the barrier is going to be by the endothelium. Basically, so at the level of the 4th week of gestation. But now, when the child now is later in life, the barrier is now going to be formed only by the syncytium and by the endothelium, because the cytotrophoblast are going to regress. Is it clear? So later in life, it's only going to be formed by the syncytium and by the endothelium. Now, preeclampsia. So preeclampsia is maternal. Is characterized by maternal. It's a systemic disease characterized by maternal hypertension and proteinuria, which occur of unknown etiology, which occur after the second half of pregnancy. That is after 20 weeks of gestation. Is it clear? And then in this case, there are different risk factors, and mostly the risk factors of hypertension are similar with that of preeclampsia. Other risk factors are preeclampsia, a history of preeclampsia, a multiple gestation, and all that. So may give you risk factors of preeclampsia. Now, the next thing that you have to visualize now is this is a section of a 6-week embryo which show amniotic sac. So here you can visualize the amniotic sac which has been opened up. So here you can see the chorion here, which are here. This is the chorionic cavity here. This is the yolk sac which is connected outside. This is a yolk stalk, the stalk here, the connecting stalk. This is the amnion. The amnion is because it has been opened all through, so the amnion can be seen very well. Now, the structure of the placenta, as I've initially said, so this is still your embryo which has implanted. So when the embryo is implanted, it has chorion fundosum. Those chorion fundosum can be considered as the villi which are present here. The decidual basilis is the part of the endometrium which is not going to be shed, while the decidual functionalis and capsularis is now the part of the decidual capillaris, now the stratum functionalis now of the stratum functionalis of the endothelium, which can be shed off and which contain many blood vessels and umbilical glands. Is it clear? Now this is the yolk sac here. This is the uterine cavity. Now outside the yolk sac, this is the chorionic cavity which is outside here, while inside you have the amniotic membrane. Amniotic cavity is going to directly cover the fetus, and it is made up of embryoblasts. Is it clear? That amniotic membrane is made up of embryoblasts. It's going to directly cover the fetus, and it's made up of embryoblasts. Now, the amniotic cavity is what is going to be engulfed and exchanged in order to produce the intra-embryonic cavities, such as the pericardial cavity, peritoneal cavity, and the pleural cavities in the body of the child. Is it clear? Now later, you see, this is the amniotic cavity. The chorionic cavity is going to reduce, and the amniotic cavity is what is going to remain outside with the placenta here. Now this diagram here shows a 19-week fetus in natural position. So this is 19-week fetus. Here you can see the placenta, but here there is a myoma, a uterine fibroid here. Now this is another diagram showing the chorionic villi, the cervix of the uterus, the umbilical cord at 23 weeks of gestation. Now the placenta in the second half of the fetus, how does the placenta go? So you see the amnion, this is the chorion plate. So this is how the placenta is. So at the beginning, the placenta is going to be like that. Then later you have a decidual septum. Then later you're going to have spiral arch is going to grow inside the placenta. Then you're going to have a decidual plate like that in the placenta. Then you have the endometrial veins, and then this is the umbilical cord that is going to supply the placenta as shown here. Now, generally, you need to know that the gross morphology of a placenta consists of two parts. You have the fetal side and the maternal side. The fetal side is made up of amnion, while the maternal side is made up of chorion. Is it clear? And that chorion is made up of different cotyledons. And this is why inspection of the placenta is very important when you are walking. Is it clear? So that chorionic side is covered by a small membrane layer, and this membrane layer contains cotyledons. So these are cotyledons, and those two cotyledons, so this is the decidual basilis, is this one here, which is removed. It's a small membrane that covers the different cotyledons on the chorionic side. Is it clear? And those cotyledons, they are 15 to 20 in number. It is required to inspect those cotyledons. When the child is born. Is it clear? Because the low level of cotyledon may show a placental retention. So you have to remove those placenta by a uterine revision. Is it clear? Now the next clinical correlation here is erythroblastosis fetalis and fetal hydro. Since you are speaking about a fetus, now you need to know that there are three main genes involved with rhesus incompatibility. We have C rhesus gene, we have D rhesus gene, and we have E rhesus gene. Is it clear? C and E both have an autosomal dominant and autosomal recessive gene. That is, there is big C and there is small c. The big C is the dominant form, while the small c is the recessive form. The big E is the dominant form and the small E is the recessive form. While D only has one form. There is no dominant or recessive. There is only one big D. So are you getting? So, and all this make up the rhesus antigen spectrum. Now inside the rhesus antigen spectrum, there is one which is the most important, which is the rhesus D antigen, because it is the one which has more of the disorder, which can cause most of the hemolytic disease of the newborn. Now we need to know that this D antigen, when the mother is rhesus negative and the child is rhesus positive, when the child is the first child who is exposed is not going to have any disease. Is it clear? It is only when that first child go out and then there is a contact between the maternal blood and the fetal blood. So when we need to know that when the child is labor occurs, there is excessive contraction, so some blood of the child may spill off into the mother circulation in a probability of 17%. So 17% of probability, 15 to 20% of probability, that is exactly 17%, may there may be a course of blood from the fetal to maternal circulation. So now when that blood, which consists of rhesus positive antigen, that is a D positive antigen, is going to enter the mother now is going to produce antibodies that is going to be in circulation. Now when the mother has another pregnancy with and the child now comes again to be rhesus positive, that child is going to suffer now of erythroblastosis fetalis, because those antibodies are going to attack that child to cause now a hemolytic disease of the newborn, because there's going to be excessive hemolysis in the child. When there's excessive hemolysis in the child, the heart is going to have the tendency of pumping excessively hard. And when the heart is going to pump excessively hard, that's why it's going to cause a heart failure. And that heart failure is going to be characterized by congestion inside the upper limbs, congestion inside the face, congestion inside the peritoneal cavity, inside the pleural cavity, inside the pericardial cavity, and inside the interstitial fluid compartment. Is it clear? Now hydrophytalis, when you have hydrophytalis, it's just defined as a congestion in at least two cavities. It can either be the peritoneal cavity, it can be the pleural cavity, it can be pericardial cavity, it can be interstitial space cavity. So congestion in one of those two spaces is called hydrophytalis. Why hemolytic disease of the newborn is only when you have excess hemolysis. It can be due to an ABO incompatibility, or it can be due to a rhesus isoimmunization. But in case of ABO incompatibility, it's not going to be excessively detrimental, like in the case of rhesus antigen isoimmunization. Now the next one is placenta barrier. You need to know that the placenta form a barrier between the mother and the child, mostly for infectious pathogens. Is it clear? You need to know that steroid hormones and different hormones can pass from the mother to child. Is it clear? But an example of those hormones, that estrogen, synthetic estrogen hormone, which can pass from mother to child, is diacylstilbesterone. And diacylstilbesterone is a very mutagenic factor, a teratogenic factor. Why? Because it results to clear cell carcinoma. It results to clear cell carcinoma of the vagina of the fetus, and it results to many cervical and uterine malformation. Example, you have uterine didelphi, you have uterine unicornis, bicornis, unicornis, and we have different structures of the uterus. Now, this is the amnion and the umbilical cord. Now, you need to know that this generally, this is going to be said to be the umbilical cord, and what covers the umbilical cord generally is the amnion. Now, you need to know that what this part here, which is having the umbilical vessels, is a connecting stalk. Is it clear? The part which consists of the umbilical vessels is called the connecting stalk, and then there is another part here containing the vitelline vessels and the yolk sac. Is it clear? So there are two parts in the umbilical cord. We have the connecting stalk, and we have another structure which contains the connecting stalk is what contains the yolk sac, and we have the yolk stalk and the vitelline vessels. It is the yolk stalk now in the other part of the umbilical cord. Is it clear? So those are the two main structures. Now, in that structure, what do you visualize? You can see here is the intestinal loop, mostly the ileum. Is it clear? Now that ileum is going to have, this is the vitelline duct here, which contain a loop of the intestine, which is going to connect it to the yolk sac with the yolk stalk. That yolk stalk can say this here structure here is the vitelline duct, and that vitelline duct consists of the yolk stalk, which connect the intestinal loop to the yolk sac. Is it clear? Now this is the allantois. This is going to be connected to the bladder underneath, and here is the connecting stalk constituting of the umbilical vessels. Now this is the orientation that you can visualize. The diagram A shows at 5 weeks of gestation, diagram B shows at 10 weeks of gestation, diagram C is the umbilical ring, that's the transverse section of the umbilical ring at 5 weeks of gestation, and transverse section of the umbilical rings at 10 weeks of gestation. At 5 weeks of gestation, you can visualize well that there is a vitelline duct with the vitelline vessels close to it. Is it clear? And then you see the two umbilical artery, two umbilical vein, and one allantoin, and this is the extra embryonic cavity at 5 weeks of gestation on the transverse section of the umbilical cord. Now when you see the transverse section of the umbilical cord at 10 weeks of gestation, you see this is the intestinal loop inside. You see intestinal loop, you see extra embryonic cavity. This is the amnion covering all of them. These are the two umbilical vessels, this one allantoin and this is the one umbilical vein. Is it clear? Now the next is clinical correlation. What are the umbilical cord abnormality? The umbilical cord abnormality, you may have false knot. So is it clear? So the false knot is actually, you need to know that what actually the umbilical cord is very tortuous. Is it clear? So the umbilical cord, when you visualize in imaging, it is very tortuous, and if you do delivery of a woman, you are going to visualize the umbilical is very tortuous. So you may think that there is a knot formation inside the umbilical cord. So is it clear? So that tortuous ability formation of the umbilical cord is called a false knot. But sometimes the umbilical cord may produce another pathogen, which is a knot, a true knot, which is going to be detrimental to the child and cause acute fetal distress. Now, there are other pathologies called such as the single umbilical artery, and single umbilical artery can occur in cases in 2 so 1 in 200 bones have single umbilical artery. Is equal normally 1 in 200 have only single umbilical artery, and it's present in this baby in approximately 20% of cases. You may have a cardiac defect or an other vascular defect. Is it clear? You may have any cardiac defect and vascular defect. Other cases like esophageal atresia may have only a single umbilical cord, and the last case of single umbilical cord is renal agenesis. Is it clear? So those are the different cases that you have to note. Now on amniotic bands, so occasionally they are tear on the amnion. So there are certain tear on the amnion, and those tear on the amnion result to amniotic bands. Now when the limbs or different structure of the fetus now get entrapped in those tears, they can either result to amputation or ring constrictions. Is it clear? You may have ring constriction if a limb get entrapped in those tears, or you can have even amputation of a digit if the limb get entrapped in those tears. Example can be shown on this image. On this image, you can see ring constriction, so limb constriction ring. Is it clear here? Because of amniotic band, and also here you can see amputation of the big toe, and this one also wanted to be amputated because of amniotic bands. Is it clear? Now the next thing is amniotic fluid level. Normal amniotic fluid levels lie between 500 to 1,500 to 2,000 mils. Is it clear? Now when the amniotic fluid level is less than 500, it's said to be oligohydramnios. When amniotic fluid is greater than 500, it's said to be polyhydramnios. Now oligohydramnios occur in which case the clinical correlation of homeohydramnios is mostly the Porter syndrome. Is it clear? And Porter syndrome is characterized by what? It's characterized by limb abnormality and fascial abnormality, which is due to a fetus having a bilateral renal agenesis. Is it clear? That is what is described as Porter syndrome. So we have limb abnormality, we have fetal malformation with a child having bilateral renal agenesis. That's Porter syndrome. Why with oligohydramnios, usually the problem is with the polyhydramnios or hydramnios is that there is malposition of the fetus. Now, premature rupture of membrane. So, premature rupture of membrane is a rupture of membrane before the onset of labor. Is it clear? So even if labor is onset is at 24 weeks of gestation, and then there was rupture of membrane at 24 weeks of gestation, that is not premature rupture of membrane. Now preterm labor is defined as the rhythmic contraction of the uterus, rhythmic contraction of uterus associated with cervical dilatation and effacement before the onset of labor, before the 7 completed weeks of gestation. Is it clear? Now these are the fetal membranes. So now this diagram now is trying to explain now the different forms of multiple gestation. Is it clear? Now multiple gestation can be, so when you have twin pregnancy can be divided into 4. Is it clear? The first twin pregnancy is dichorionic diamniotic. The second twin pregnancy is monochorionic diamniotic. The third twin pregnancy is monochorionic monoamniotic, and the fourth twin pregnancy is Siamese twin or conjoined twins. Is it clear? Now this one here is trying to show you a dichorionic diamniotic twin. So dichorionic diamniotic twins, both of them have different chorion. Are you seeing? This is also another form of dichorionic diamniotic twins. So both of them, so this one is instead monochorionic monoamniotic twins. Is it clear? So because both of them have a same placenta and the same chorion, but they have different amnion. Is it clear? So it starts with a 2-cell stage zygote. This 2-cell stage zygote consists of the 2 blastomeres and it's called a morula. Now it continues here. We have the inner cell mass, we have the outer cell mass. Outer cell mass is called the trophoblast. The inner cell mass is called the embryoloblast. Now the embryoloblast now produces amniotic cavity, the yolk sac, and this is the plate here. All is going to divide into 2. This one is a dichorionic diamniotic. Why? Because it consists of 2 placenta, 2 chorion, and 2 amnion. Why here there's only 1 chorion, that's 1 placenta, and there are 2 amnion. So this one is a monochorionic diamniotic. Now you need to I also want to point out the fact that what dichorionic diamniotic occur when this division like that occur, the division of the 2 fetus occur before 3 days. So when it is division occur before 3 days after conception, it is going to produce dichoroidal amniotic. Now if division occur from 3 to 8 days after conception, it's going to produce a monochorionic diamniotic. If now division occur between 8 to 12 days, it's going to produce a monochorionic monoamniotic. And now if the division of the cells occur after 12 days or after 13 days, it's going to produce a Siamese or conjoined twin. So this one is a monochorionic diamniotic. Now in this case, you can see visualize the dichorionic diamniotic because division occur earlier. This is a monochorionic monoamniotic because division occur later between 3 to 8 days, and this is a monochorionic monoamniotic. Is it clear? They share both, and they have both the same chorion and the same amnion. They share the same amniotic cavity. Is it clear? Now, what are the abnormalities related to twin pregnancy? You need to know that one. Approximately 60% of twins are born preterm and also have a high incidence of low birth weight. Approximately 60% of twins. Now, many twins also, we need to also point out the fact that one, many twins die before birth, and some studies indicate that only 29% of women pregnant with twin pregnancy actually give 2 children alive. Is it clear? So, if you have 100 women having twin pregnancy from the time of conception to birth, it is only 29 of those women that are going to give actually 2 children at birth. Is it clear? Why? Because, so you see, many pregnancy can be twin, but only 29% of those pregnancy which are twin are going to be alive after labor. Is it clear? Because there are 2 main disorders, there are 2 main problems with twin pregnancy. You can have a vanishing twin syndrome and you can have a twin to twin transfusion syndrome. So a vanishing twin syndrome, what is it? So it is it's a case, it refers to death of one twin, a twin in utero. So this is a case of vanishing twin syndrome. So usually the one which are associated with vanishing twin syndrome and also twin to twin transfusion syndrome is the one which is monochorionic monoamniotic. This one is the most dangerous. Why? Because they share the same chorion and they share the same umbilical, they share the same amnion. So so the blood supply is not going to be very supportive for both of them. So one is going to try to push the blood supply toward himself and make the other to die. So when one grows and the other die, that is going to be called a vanishing twin syndrome. So you are going to give birth to both of them, but one is going to be very arthritic. Is it clear? Now the other one is twin to twin transfusion syndrome. So in twin to twin transfusion syndrome, you see one is going to be more pinkish while one is going to be more pale. Why? Because the one which is going to be more pinkish receive more blood supply. Is going to pull more blood supply from the one who is going to be more pale, and usually the one who is more pinkish die before the one is more pale. Why? Because the one who has more blood supply is going to die of heart failure, because the heart is going to pump extremely hard to that the high blood supply, while the one who is more pale is going to be anemic, but is going to compensate to that anemia till he gets born. Now these are the disorder of Siamese twin. So disorder of Siamese twin can either be thoracophagus, when the Siamese twin are connected by the thorax. It can be pyophagus, when they are connected by the abdomen and the pelvis is pyophagus. And the lastly is craniophagus. Craniophagus is when they are connected with the head. Is it clear? So this diagram here is A shows a diencephalus. So diencephalus is connected with all the body, but they only have 2 heads, and this is craniophagus here. So this is what is shown under this disease. Now the next thing is preterm birth. So preterm birth is when you just give birth before the 7 weeks of gestation. That's the next clinical correlation. Is it clear? So Before I finish, I'm just going to give you a general definition in such that you have it in mind. You need to know that when we say 1 week of gestation, 1 week, so when we say 37 weeks of gestation, is actually 36 weeks and a number of days. Is it clear? In order to understand this, you need to point out the fact that when you are in a football match, is it clear? The first minute, when you are 1 second of the football match, 1 second of the football match is considered the first minute of the match. Is it clear? So it means that 1 minute 2 seconds is going to be considered the second week of the football minute of the football match. Is it clear? So it's similar with babies. Is it clear? So when you are at the first day, it is the first week of gestation, and when you are 36 weeks 2 days, it is going to be the 37th week of gestation. So 37 completed weeks considered as 36 weeks 7 days. Is it clear? So that is the point that I just wanted to bring out. So from here we are finished with the tutorial. Obviously, thanks for kind attention. Don't forget to like and subscribe for our channel. Thank you.